Well, a warm welcome to this update. Now, if you've been reading the press at all, you'll see headline banners about this person that's been reinfected or possibly reinfected. What's all this about? And that's the purpose of this video. But if you don't want to watch this video, the bottom line is, given the data that I have got so far, I am not particularly worried. That is the bottom line of this video. But going on to the detail, if it were true that reinfection after the SARS coronavirus 2 gave someone COVID-19 again, and that could happen repeatedly, then clearly this would be a cause for concern, because it would mean that the virus would go on circulating within the community and people could be reinfected multiple times. So if that were true, that would be an issue. But is it true? Now, this is based on one paper from Hong Kong. Now, in fact, it's not even one paper. It's not even a paper yet. It's not peer-reviewed yet. And before things are peer-reviewed, it's normal to put them into these preprints that we often refer to. But it's not even in that yet. It's been circulated in the world's press, and the only original source I can find is actually about 4 or 5 leaked pages from this preprint on Twitter. Now, it does look like a genuine preprint, so I'm quite happy with that. But basically, we've nothing to hang our hat on at the moment. And Dr. Marie from the World Health Organization said she hadn't read the paper yesterday. So if she hasn't read it, basically the paper's not available. But I managed to put together these pages from this almost sort of a spy camera clip on Twitter. So what's it all about? So I do have some detail. I'm not wasting your time entirely. So reinfection is the question. Is it possible? Now, this is Dr. Kevin from Hong Kong. He's a proper microbiologist, so a very credible medical man. And he's reporting the first case of reinfection. Now, this does seem indeed to be the first case in the world. Now, there was a lot of talk about reinfection for months now. And we were talking about some cases on this channel about some people that appeared to be reinfected in South Korea. But it turned out they were just shedding the virus sometime after they'd recovered from the acute infection. Not an infectious form of the virus in that case, so that was fortunate. So there's been a few sort of false alarms, but this is the first case. So Dr. Kelvin Kia Wang here is reporting the first official confirmed case of reinfection. Now, we've been looking for this for some time. There's been 24 million opportunities of people infected in the world to get this. And Dr. Kelvin Kia Wang is the first person to come up with one case. So this is one case out of 24 million. So that puts me at ease a little bit more straight away. 23 point something million, just under 24 million cases. Now, the Hong Kong Institute say that this is going to be published in the Journal for Infectious Diseases, a reputable journal. They say it's going to be published in that. We haven't yet seen it, of course, so we don't actually know, but I'm no reason to assume that they're being disingenuous about that at all. I think we can look forward to seeing this in the Journal of Infectious Diseases, but it's not there yet and it's not peer reviewed. And I actually looked at the pages that we had as the preprint, and I found, just with a couple hours reading, I found what I thought was a mistake. We'll come on to that later. This is why peer review is so important. You need people really to scrutinise before you get into the area of publication and being definitive about anything. So lots of public, lots of news outlets, but this is the only original one I could find. And there's about 4 or 5 pages from, looks like a spy camera. You can't cut and paste it or anything. It's just there on this Twitter link. So I did have a good look around. If you know where it is, if you know where the preprint is formally published, do let me know, but I couldn't find it. Now, the authors are saying this is not a case of prolonged viral shedding. So they're saying this is different from the cases in South Korea. This is not just some residual virus, this is reinfection. And it's a 33-year-old man and is reported by the authors in the paper to be in good health. Now, various news outlets say he's immunocompetent, but that's not in the original paper. Now, I've no reason to assume he's not. He's a healthy 33-year-old man, but there is a bit of he said, she said in this already, unfortunately. Now, his first infection, and this is straight from the sort of spy shots of the original paper. First infection, 3 days, cough, sore throat, fever, headache. He was hospitalised in Hong Kong, and they did take antigen swabs. Now, 10 days after he was hospitalised, he was negative for immunoglobulin. So this gentleman did not seroconvert. He did not make antibodies. Now, the vast majority of people that are infected with SARS coronavirus 2 do make antibodies. Now, you can read various papers that gives proportions for those that don't seroconvert after confirmed antigen, virus confirmed COVID-19 SARS coronavirus 2 infection. And it seems to be around about 8 or 9% that don't seroconvert. So not entirely surprising. Because remember, really, there's 3 lines of immunity here. There's the immunoglobulin type A's in the mucous membrane. There's the immunoglobulin G's. We now know immunoglobulin G is the main one that converts in the blood. But of course, there's also the T cell response. And the T cell response is probably the most important in terms of longevity of the response. But anyway, this chap did not seroconvert on his first illness, despite having a definite antigen test. He was definitely diagnosed, as we will see. So on the 26th of March, he had an oropharyngeal antigen PCR diagnosis, definitive diagnosis. So I'm happy with that. He did have this disease on the 26th of March. And on the 14th of April, he was discharged from hospital asymptomatic. Now, that's quite a long time to be in hospital, actually. I'm not quite sure why he was in hospital. The paper doesn't actually say how long he was in hospital. It just says he was symptomatic for 3 days. So part of the story missing there already. We don't have the full account. It's simply not in the public domain at the moment. But we do know he was discharged from hospital on the 14th of April, was asymptomatic. Then there was a period of 142 days. So there's a gap of 142 days between the first infection and this second, I was going to say reinfection then, second infection. He has become infected again. I think there is evidence for that. But of course, remember, this is 1 man out of 23 million men and women who've been infected in the world already. Now, 142 days gap, and he flew from Hong Kong to Spain to the UK to Hong Kong, as far as we can gather. He flew home from Spain and he might have just had a bounce off in the UK. Maybe he didn't leave the airport. We're simply not told. We don't know that. But we do know he was in Spain and then probably via the UK came back to Hong Kong. So that is known. Now on the 15th of August, he arrived back at Hong Kong airport, and of course everyone coming in there was going to be tested. So he had an oropharyngeal swab again at Hong Kong airport and was found to be positive. And of course he knew that he'd been positive before, so this is automatically an interesting case. So because he was an interesting case, they took him to hospital in Hong Kong. He was not symptomatic. He was asymptomatic. Had he not been tested, he would never have known he had the virus again. And he didn't become symptomatic. So his original March infection was symptomatic. The reinfection in the middle of August was never symptomatic. He remained asymptomatic. He felt fine. As far as we know from the data in the paper, he felt fine. But he was hospitalised but remained asymptomatic. It was obviously an interesting case. Temperature 36.5, that's 98 point, probably about 98.2 or something. Anyway, it's perfectly normal. 98.2, I would say. Yeah, probably about 98.2. Anyway, it's perfectly normal. Heart rate was 86, bit fast, but he was in hospital. Blood pressure 133/94, tiny bit high, but he was in hospital. Oxygen saturation is 98% on room air, which of course is normal. Now, CRP stands for C-reactive protein, and it's an inflammatory marker. So we take blood, and if the CRP is raised, that means there's some inflammatory process going on in the body somewhere. It could be a viral infection. With a bacterial infection, the CRP is often much higher, but it could be because you've got an injury as well. Any inflammation in the body will raise the CRP. And his CRP was 8.6, so that's a bit raised. It's slightly raised. It's not it's not a massively increased CRP. So slightly increased C-reactive protein, meaning there was some inflammatory process going on in the body. And the authors of this paper assumed, and I think it is an assumption, they did assume that this slightly raised CRP indicating a degree of inflammation in the body was caused by viral infection. That was their assumption. I don't know of any proof that they gave of that, but again, it's not unreasonable. It's not unreasonable. So the CRP was slightly raised, suggesting acute infection according to the authors of the paper. But the CRP did go down in his time in hospital, meaning that the level of inflammation in his body went down when he was in hospital. Now, they did say he had hypo, low, cal in the blood. Low, hypo, cal is potassium, emia is in the blood. So he had slight hypokalemia. So his potassium was slightly low. They didn't say what it was. That was simply not reported, and they didn't say it was significant. So it doesn't sound like he had a severe hypokalemia. It wasn't mentioned again. It was almost a sort of throwaway line. Now, the viral load, he was repeatedly tested in hospital, and the viral load, this is in the middle of August, progressively decreased. And serum on day 5 of hospitalisation became positive. So at this time he did seroconvert, he developed the antibodies, whereas last time he hadn't. So definite antigen diagnosis here on 2 occasions. So yeah, this one person out of 23 million was reinfected. And we have been looking for this for some time now, but this is the first documented case. Now, if we start getting thousands of cases in the next few weeks, I'll start to get a bit worried. But at the moment, I am not overly concerned at the moment, because this is just one case. And there's other factors as well that we'll see. Now, genomic analysis of the virus. Looking at the genetic makeup of the virus. Now, full sequence was performed after the first and second episode. Now, it's a good job he was in Hong Kong, I suppose, because we wouldn't normally do a full sequence of the virus in many other places. But he had a full genome of the virus performed in the March episode and in the August episode. And the viruses were found to be from different lineages, different clades. So what happens is, like a virus here will be, a virus will mutate into 2 different types of the virus like that. And then this will carry on reproducing into many more groups of the virus, and this likewise will go its own sweet way. It could start reproducing in a different country, for example, and we'll get more cases here, like this. Now a clade is like a subset like that. So that would be one clade there. That would be that clade, and that would be another clade there. So what they're saying is that the viruses was infected with in March and the virus was infected with in August were from completely different groupings and completely different lineages. So different clades and lineages. Now, what they found, now the paper said there was a truncation of 58 amino acids in the virus genome. Now, that is directly from what the paper said. And to me, that makes no sense whatsoever. Biologically, that doesn't make sense. So they were saying that there seems to be 58 amino acids cut off, but the genome is not made of amino acids. So it simply didn't, what they say there simply doesn't make sense. And this is why this paper needs peer review, because I think that's an error. 58 amino acids in the virus genome, to me, is a nonsensical statement, because the genome is made up of the bases, the RNA bases, not of amino acids. So anyway, we'll let them off with that bit for now. Peer review should check that out. But they did say there was 23 nucleotide changes. These are the bases that make up the RNA. 13 of which were non-synonymous mutations. That means they can affect the arrangement of the amino acids in the proteins. And 4 of those amino acids were in the spike protein. And I'm not going to draw the diagram again because we've done it multiple times. But the spike protein is the part of the virus that fits into the cells to allow it to infect the cells. So there was a slight change in the spike viral protein, but they didn't say what part of the spike it was, how important that part of the spike was. But it looks like what we've got here is from the single virus that from patient 0, we've had all these mutations and these different varieties of the virus have emerged. And indeed, we were talking about that just yesterday, in fact. So again, the genomic analysis, that's relatively straightforward to do for biochemists these days. I'm happy that will be genuine. Now, the first strain, the smart strain, most close to the strain in the USA or England, most closely to the strains collected in the United States or England in March or April, as you would expect. The second strain is most closely related to strains circulating in Switzerland in England, collecting in July and August. So most closely related to strains circulating in Switzerland and England in July and August. And he was infected in August, but we were presuming in Spain. So we would assume that there's versions of that virus in Spain, unless he was unfortunate enough to pick it up as he was transiting through England. Again, limited information about his journey. We can't make definitive statements. So they did. So what's the evidence? What's the evidence for reinfection here? Is there a convincing case that this single individual was reinfected? The answer is yes. Let's look at the evidence. The evidence is from the genomics and the phylogenetic analysis, the two different types of virus, the 142 days in between. Now, the previous record apparently is 104 days for a woman who was pregnant. So people don't go on shedding the virus for 142 days. Typically, it's only going to be a few days. Very unusual to be more than a week. Very unusual to be more than 2 weeks. But this one woman who was pregnant, therefore probably a bit immunocompromised, potentially, was 104 days. But that's a single case. Most people are like, not more than a couple of weeks. But this one's 142 days, so it's too long. We wouldn't expect the virus to be dormant for that amount of time. He had the raised CRP indicating he did have an acute infection, assuming he didn't have any inflammatory processes anywhere else in his body, that is, which the article didn't say. And the patient had recently returned from Europe with July and August strains from Europe, so consistent with a visit to Europe. So the evidence there, 2 positive antigen tests. I'm happy that he was genuinely reinfected from those 2 positive antigen tests. Now, as we've said repeatedly, this is one individual. We can't make too much from this. But if it were that people were easily reinfected, then you could see why the world's press has become so animated about this. But I think it's a bit of an overreaction, given the amount of scientific information on this we simply do not have. We haven't even got the preprint, never mind the peer-reviewed paper. So we simply don't know yet. Anyway, the Hong Kong group go on to give implications. They say it's unlikely herd immunity can eliminate SARS coronavirus 2. Don't agree. This is one case. It's one case. To go from one case to saying we're not going to get herd immunity is, to me, is an over-extrapolation of just ludicrous proportions. SARS coronavirus 1's been eliminated from the world. I think this one can be as well. Yes, there are 4 other types of circulating coronaviruses that cause the common cold. But to say from one person that was reinfected once that we're not going to reach herd immunity in the whole world, nah, over-extrapolation. Subsequent infection is likely to be milder. Okay, that's a fair point. So he had a symptomatic infection once. His second infection was milder. So if there are subsequent infections, if there are any more, and at the moment we don't know of any more, but if there are any more, because this one was milder, does that mean the others will be milder? Probably. The reason I'm saying probably there is it kind of makes immunological sense. Not that we can extrapolate from one single case. What other implications are this group saying? Virus seems to go on circulating. Virus likely to go on circulating in the human population. In other words, they're saying this virus is likely to go on circulating for, well, they didn't say how long, potentially years or decades, I think is their implication, because of this single case of one person being reinfected. Don't agree. Can't extrapolate that from this. In fact, it surprises me that scientists of this calibre are making such assumptions from a single case. I am actually taken aback And I wouldn't be publishing these if they weren't in the preprint. Now, having said that, the preprint is just the spy copy. So if I am misrepresenting these doctors from this leaked paper, they have my unreserved apologies. But the whole of the world's press is doing the same thing. So it won't just be me that's guilty of misrepresenting them. Vaccines will not provide lifelong protection. I've got an infection there. I meant protection. Again, well, I can't agree because it's one case. You know, if there was thousands of such cases, then yes. The idea is that the virus could have changed enough that the vaccine antibodies no longer recognise it. But we don't know that yet. This is one isolated case. Time will tell. I remain optimistic that one vaccine will give immunity to all the viral strains in circulation in the world. I remain optimistic about that. Part of the reason I'm optimistic about that is the people that are making these viruses are well aware of these viral mutations and have accounted for that by taking parts of the virus as their immune target. That is very unlikely to change. The people developing these vaccines are smarter than the average bear, certainly smarter than me. They've taken these things into account. Vaccine studies should include patients who have recovered from COVID. Well, okay, I can agree with that. So vaccination studies should include people that have recovered because we simply don't know at the moment. So people that have COVID-19 could still be included in vaccine trials. That's not unreasonable. They could form a cohort in a vaccine trial. People who've had COVID-19 should be vaccinated. Well, no, I think it's too early to say that. Now, of course, the people that decide who gets vaccinated are going to be the senior health officials at the time. But again, to say that if you've had COVID-19, you should be vaccinated from one case, not a cohort, I would want someone well above my pay grade to make that decision, that's for sure. I'm sceptical about that. We would know, of course, if they were included in the vaccine trials, then we wouldn't be guessing. So that, if they were included in the vaccine trials, would inform that decision. But to make that decision but based on one case now, I don't think so. People who have had COVID-19 should continue with public health measures. Right, what they're saying here is if you've had COVID-19, you may still be susceptible. So you should still carry on taking all the public health measures. Okay, I'm going to agree with that one for the time being because it's the safe option. It's the safe option at the moment. We don't know, but it's if they do obey public health measures and it turns out they are immune, then nothing lost. And as well as that, I think everyone has to be seen to be obeying public health measures. So if you saw people who weren't obeying public health measures, we don't know whether they're immune or not, and that's kind of setting a bad example. So at the moment, I agree, everyone should follow the public health measures that we are constantly reminded of. What else are they saying? Residual low levels of antibodies may have controlled the second infection. Now, I found this telling. The group was saying that the person who was infected, the 33-year-old man, even though he was tested for antibodies way back in March and did not have any, he didn't have any in March, and we know that the numbers go down with time. This Hong Kong group is saying he may still have had enough to protect him against symptomatic disease, meaning he only had asymptomatic disease. That's straining a lot out of the tea bag, that really is. So he tested negative for antibodies, but we still think his antibodies was enough to cover him 142 days later. To me, and again, I don't really understand this because these are very reputable scientists. Why did they make no mention of T-cell immunity? Now, in the part of the paper I read, there was no mention of T-cell immunity. There was no mention of immunoglobulin A, mucous membrane acting antibodies. But the key thing is they didn't seem to take into account the fact that there is T-cell induced immunity, as we've looked at many times on this video. Because remember, the T cells can directly kill the infected cells and the other T cells can stimulate the B cells to produce the antibodies. And yet they say that their explanation for why he was not symptomatically ill was because he had residual antibodies, which didn't appear to be there. I thought that was a very weak statement by this team. In fact, the whole paper I thought was really quite weak and has not raised my anxiety levels actually. Now, Dr. Marie van Kerkhove from the World Health Organization was asked this question yesterday. Yesterday's briefing from the World Health Organization, and yesterday she hadn't read the study. The reason she hadn't read the study is it's not available. So it looks like she's got the same problem as me. She couldn't find it. So if she hasn't read it, I've only read this spy copy. Our expectations, people who are infected with the virus develop an immune response. I agree with her. I expect them to be immune. People do develop an immune response. Not completely clear yet how strong and how long that response is. So this is true. So what she's saying here is we know people do develop an immune response. We don't know how. We know that from antibody studies. We know that from T-cell studies. How good that is and how long we don't definitively know. But to me, the intimations are that the immune response is going to be good and could well be long lasting. From the data that we've looked at just on this channel over the past couple of weeks, that's my current belief. This Hong Kong paper doesn't change that yet. We're open to further evidence, of course. Of course. Dr. Maria is saying severe, mild and asymptomatic cases all develop an immune response. And we did look at this just the other day as well. So even people that were minimally symptomatic or asymptomatic still developed an immune response, which is good. She pointed out more than 24 million cases, so we can't look at one case. We have to examine this on a population level. We need a cohort of people in a population. And even if it does turn out to be a common phenomena, we need to look at populations to work out how this is epidemiologically significant, because that's what epidemiology is. It's the health of populations. This is one case. Dr. Maria pointed out longitudinal studies are following up now. So there's longitudinal studies going on now. We will know this soon, but we don't at the moment. Now, what I think is going on here. Have you heard of this one, inductive and deductive thinking? Inductive thinking is bottom up. Deductive thinking is top down. So like inductive thinking says, well, if this is true in one instant, it's always true. And my patients are always doing this. They'll say, John, last year I had depression and I had fluoxetine. So now my mate's depressed, so he needs fluoxetine as well. Or my Agnes, she had this chest infection 3 years ago. Doctor gave her the red pills. I've got a chest infection now, therefore I need the red pills. You see, people tend to say, because it worked for me, it works for everyone. That's inductive thinking, and it's intrinsically illogical. The whole point about research, the whole point about cohort studies, is you get 1,000 or 2,000 or 10,000 people, and you work out what is generally true for them. And if it's true for 10,000 people, then it's likely to be true for the individual. That is deductive thinking. So inductive thinking says, because it's true for me, it's true for everyone. In other words, they're extrapolating a general principle from a specific instance. People tend to do that, but it's intrinsically irrational. It's not true. Because I take size 10 shoes, you take size 10 shoes. Because I like tea and cheese and onion crisps, you like tea and cheese and onion crisps. It's just completely irrational. We can't do this. And yet that, to me, what this study is doing. Because it's true in this one person, it's going to apply to the whole wide world. Now, I need more evidence first, I'm afraid. So the rational thing is deductive thinking. That's why we have cohorts. If it's true in the general, then it's reasonable to extrapolate a specific instance from a general principle. So a general principle, for example, might be that all human beings need food, that therefore I'm a human being, so I will need food. All human beings can protect their feet better wearing shoes, therefore, because I'm a human being, my feet are going to be more protected wearing shoes as well. All human beings need social interaction and company. I'm a human being, therefore I need social interaction and company. That's deductive thinking, and that's intrinsically logical, and that's why cohort population studies are necessary. So I think I might be being over cynical here, but I think they've succumbed to a bit of inductive thinking, going from the bottom to the general principle, rather than deductive thinking, going from everyone down to the individual. As always, it's a novel virus. We are awaiting more data. As of now, I really don't think we have it. Thank you for watching, as always.